everyone, myself Pampi Mahatro, Department of Physiotherapy, Assam Downtown University. Today we are going to discuss on the topic examination and management of acromioclavicular joint injuries. In my last video, I have already discussed about the types of acromioclavicular joint injuries. So today we are going to proceed with the examination and then we are going to see the treatment for acromioclavicular joint injuries. So at first let's check out the main points that we need to assess in examination. So the first is history. Obviously history is very much important. We need to understand the mechanism of injury, and based on the mechanism of injury we can find out what is the diagnosis. So that's why history is very much important, and based on history we can also formulate which type of AC joint injury is present. Next, we need to go for observation of the static position of the shoulder joint. So we need to observe the shoulder girdle. So in my last video, I discussed about the prominence in the distal clavicle. So if you check out the image present here, can you see here the prominence over the distal end of clavicle? So this will be noted in case of severe AC joint injury. So if this is present, it indicates AC joint injury. Next, we'll have palpation of the AC joint and surrounding structure. So we'll go for palpation to check out for tenderness. If tenderness is present over the AC joint, then it's indication for AC joint injury. Next, provocative test. So there are various tests which we are going to discuss in the next slides, which will determine whether an AC joint injury is present or not. And finally, radiograph. So we can go for X-ray as well as bone scans. So now let's progress with the examination in detail. So the assessment of AC joint injury will be similar to any other assessment for the shoulder complex. What I'm explaining here is only the main points that shows or presents in case of AC joint injury. Okay, so the first point, as I've already mentioned, is history. So in history, we need to understand the mechanism of injury, which I have already discussed in my previous video. So here, this mechanism of injury as well as palpation of the AC joint also helps to differentiate between type 1 and type 2 type of injury. So there will be a minor deformity in the AC joint in case of type 2 injury and above, but it won't be there in case of type 1 injury. The next thing that will help us to differentiate is in case of type 1 injury, there will be swelling, and along with swelling, there will be pain on abduction of the arm. But in case of type 2 injury, there will be pain in all movements of the arm. So this is a definitive differentiation for type 1 and type 2 AC joint injury. Next, in case of type 3 AC joint injury, there will be a step deformity over the AC joint. So while palpating, if we find the step deformity, it's indicative of type 2 type of injury. Okay, so now let's go for palpation. Since observation I've already discussed in the previous slide. So in palpation, then if tenderness is present over the AC joint itself, it will be considered as indicative for AC joint injury. Next, the provocative testing. So there are four main provocative tests for AC joint injury. These are Peck's sign, cross-body adduction test, resisted AC joint extension test, and O'Brien test. So these four tests will check out one by one in the next slides. And last, bone scanning. This bone scanning has been found to be a reliable imaging modality for the diagnosis of AC joint pathology along with X-rays. So these are the points that we need to stress out during assessment or examination of AC joint injury. Next, let's check out the Peck's sign. So what is the purpose of performing the Peck's sign? The purpose is to detect the presence of AC joint pain. Okay, so how to perform the sign is with the patient sitting and the symptomatic arm by the side, the examiner's thumb is placed under the posterolateral aspect of the acromion, and the index and middle finger of the same or contralateral hand are placed superior to the mid-clavicle. Okay, so this is the position of the therapist as well as the patient. Next, the examiner provides pressure to the acromion in a anterior-superior direction with the thumb. Okay, and the examiner also provides pressure in inferior direction to the mid-clavicle with the index and middle finger. Okay, so when this pressure is applied, if pain is felt or the pain is increased over the acromioclavicular joint, the test is considered as positive. So this is what is Pecciano's sign. Next, let's discuss the scarf test, or it's also known as cross arm adduction test. So what is the purpose of this test is to find out AC joint pathology. So this test is not indicative for only AC joint injury. Any type of AC joint pathology we can determine with the help of the scarf test. Okay, so in other words, we can say it's not a definitive indication for AC joint injury. Okay, so now let's check out the procedure. So the starting position is with the arm to be tested in 90° of elbow flexion and 90° of shoulder flexion. So with this position, we'll go for adduction, okay, horizontal adduction, resting the hand on top of the opposite shoulder. So this is the position. After that, what the examiner will do is the examiner pushes the arm further into adduction. Okay, so the position mimics throwing a scarf over the shoulder. So that's why it's known as scarf test actually. So it's considered as positive if there is a localized pain over the acromioclavicular joint. Okay, so this is the cross arm adduction test. Registered AC joint extension test. So the purpose of this test is to identify acromioclavicular joint pathology in both traumatic and non-traumatic chronic overuse cases. It also helps in differentiating between AC joint and impingement syndromes. So the technique for this test is the patient position will be in sitting position and the therapist will be standing behind the patient, and the patient's shoulder is placed in 90° of flexion and internal rotation along with the elbow in 90° of flexion. So in this position, the therapist places his or her hand on the patient's elbow and asks the patient to abduct the arm. So to this abduction of the arm, the therapist provides an isometric resistance. Okay, so the result will be if there is a pain during the abduction movement that is restricted by the opposite movement by the therapist is in the AC joint, then this test is considered as positive for AC joint injury or any pathology of the AC joint. So the last test is O'Brien's test. The purpose of O'Brien's test is that it indicates whether it's a potential labral tear, for example, a slap lesion or acromioclavicular lesion that is a cause of shoulder pain. It also helps to determine acromioclavicular joint pain. Okay, so the technique for this test is the patient can be in sitting or in standing position. The tested extremity, that is the extremity to be tested, is placed in 90° of shoulder flexion along with 10 to 15 degrees of horizontal adduction. Okay, so in this position the patient is asked to go for internal rotation and also pronation of the elbow. Okay, so in this position the examiner provides a distal force to the patient while the patient applies the upward force. Okay, so this is what is the O'Brien's test. A positive test occurs when there is a pain or clicking in the shoulder with the first position and reduced or absent in the second position. Okay, this is again repeated in the opposite side. So this is all about the O'Brien's test. The depth of symptom must also be assessed, as superficial pain can be indicative of acromioclavicular joint, and if it is a deep pain, it's a sign of labral tear. So next we'll discuss about the radiographs, that is mainly x-rays are done. The x-rays are done in mainly four planes, that is AP, that is anterior posterior, axillary, lateral and Zenka views. And should be taken with the patient upright and no support of the injured arm. So here I am showing the Zenka view here. So as you can see, it's 10 to 15 degree of cephalic tilt is there while taking the X-ray. Okay, next is the axillary view. So if you can see properly, it assesses the horizontal displacement. So this is the axillary view. So these are some X-ray slides for the type 2, 3, 4 and 5. So as we all know, in type 1 there is no change in the X-ray. So from type 2, if you can see here, so I can show you with the help of a pointer. So see, here is the acromioclavicular joint, right? So as you can see, there is a slight displacement, not much. And then in type 3, so here is the AC joint, you can see properly there is a vast gap between the acromion and the clavicle. Okay, so this is type 3. Next is type 4. So if you remember my last video, so what is type 4? In type 4, the distal clavicle moves posteriorly, right? So as you can see, this is the acromion, the clavicle is posterior to the acromion. So right, so this is the type 4, and this type 5, if you remember well, the distal clavicle moves vertical. Okay, so as you can see here, this is the acromion, and the clavicle, the distal end has moved upward. Okay, so this is some examples of X-ray findings in case of type 2, 3, 4 and 5 type of AC joint injury. Now, since we have completed the assessment part and we will formulate the diagnosis in this case as AC joint injury, we need to go for differential diagnosis, as many conditions around the shoulder may mimic as AC joint injury. For example, instability of the AC joint or slap lesion, or impingement syndrome, anything. So we need to go for differential diagnosis with the help of the assessment, that is the provocative testing, the observation, palpation and everything, and then the x-rays. So correlating all the signs and symptoms will go for the final diagnosis. Okay, so this is all about the differential diagnosis. Let's start with the treatment now. So the treatment for type 1 and type 2 is mainly conservative. So we'll mainly go for rest and use of sling, as well as painkillers. We might go for cryo if it is an acute pain, and in case of severe pain we can go for anesthetic injection. So the period of immobilization in the sling is usually 7 to 10 days in case of type 1 and up to 2 weeks in case of type 2. So once acute pain has subsided, we can start with the rehabilitation. Next, for type 4, 5 and 6, we definitely have to go for operative intervention, as all the stabilizers, the static and dynamic, are injured. Okay, so if you remember properly, I have shown this diagram in my previous video. So still I'm putting this chart here. So if you see the last point here, the treatment part. Okay, so the treatment part, if you see properly, I have given sling for type 1, type 2, and 4, 5, 6 I have given surgery, but I have mentioned the type 3 as controversial. I have also explained why it's mentioned as controversial, as we can go for both, that is conservative or surgical management, depending on the severity of the injury in case of type 3 AC joint injury. So now let's progress with the operative techniques that can be used in case of AC joint injury. So there are mainly four most common surgical procedures that are done. That is AC joint fixation using hook and plates, coracoacromial ligament transfer, coracoclavicular interval fixation, and coracoclavicular ligament reconstruction. So all these procedures are depicted here. We don't need to go in detail for now. Okay. About today's presentation, we have discussed about the examination as well as the medical management for acromioclavicular joint injury. In our next video, we'll discuss about the rehabilitation. So I hope you join me in the next video as well. Thank you.